Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.AAAAI.org. Today's edition of our Conversations from the World of Allergy podcast series is from our Hot Topics series, and we'll discuss a new biologic treatment for asthma. The information discussed today will be applicable for patients, the general public, and medical professionals as well. We are pleased to welcome Dr. Roxana Siles to our episode today. Dr. Siles is an allergist in the Department of Allergy and Clinical Immunology at the Cleveland Clinic, where she also serves as the co-director of the Asthma Center. Dr. Siles' area of interest lie in the management of severe asthma and addressing health disparities related to asthma. Dr. Siles is the current chair of the American Academy of Allergy, Asthma, and Immunology Asthma Cough Diagnosis and Treatment Committee. With that, Dr. Siles, thank you so much for taking time out of your schedule to join us today, and welcome to the show.
Thank you for having me. I appreciate it.
Well, your expertise is going to be very helpful as we understand this new treatment. But before we get into that, I'd like to learn a little bit more about you, if we may. And much of your career is really focused on asthma. If you don't mind sharing, what drew your interest towards this condition and why do you find it so fulfilling?
Well, as you know, asthma is a common condition and it affects millions of people across the world. And I find that it has a huge impact in the quality of life of many of our patients. What drew me in this area is a tremendous amount of research that has been taking place in the last few years. And now we have different forms of therapies that can really make a huge impact in the lives of our patients. I find that very rewarding, and that's why I've been more dedicated to asthma care.
Yeah, it's very exciting times for asthma in regards to better understanding diagnosis and treatment, and we're going to talk about a lot of these different breakthroughs very soon. Before we get into that, we do have a very broad audience of listeners typically, and I think it might be useful just to make sure everybody's starting with the same background information. So along those lines, can you start with just a basic description of what asthma is so everybody understands, and then from there we can discuss some of the important differences?
Sure, absolutely. Asthma is a chronic condition of the airways, and it is driven by inflammation. I think that's the key fact. And inflammation is triggered by allergens, viruses, irritants, and in turn, inflammation contributes to bronchoconstriction. So this leads to symptoms of cough or wheeze or shortness of breath or the sensation of chest tightness. It's also important to know that it seems like no two patients are alike. Some may only cough while others may only wheeze, and then we have others who have all of those symptoms. We also have those patients who may experience asthma symptoms only related to exercise, whereas others may have more problems around their cat. So I think it's very heterogeneous and fascinating disease.
Mm-hmm. And you mentioned some of why you're so passionate about asthma is just how much we've learned over the last 10 to 20 years, and especially regarding different types of asthma. So along those lines, what do the words phenotype and endotype mean? Can you help us better understand that?
Yes, I think those are very important terms to help understand this condition. So phenotype referred to recognizable clinical characteristics or actual demographic features of the condition. So it is, it seems like the more we learn about asthma, the more we find patients who have different subtypes of the disease. When it comes to endotypes, well, that is actually a term used to describe the mechanism at the cellular level or the molecular level. And I think it's important to review some of the key players involved in asthma. So I can certainly just do a quick brief overview. We definitely have those T cells that are in the asthmatic airway. They produce cytokines, some of which we all recognize, like IL-4, IL-5, IL-13, and IgE. And then we have these cytokines that play a key role in inflammation and allergic cascade that is associated with asthma.
And so that would go along with endotypes. Can you tell us about some of the main asthma phenotypes? Because as you mentioned, that's more of like a clinical characteristics, correct?
Absolutely. So some of the phenotypes that are common in asthma include allergic. We also have non-allergic, aspirin-sensitive asthma, occupational asthma, eosinophilic asthma, and non-eosinophilic asthma. So each of these phenotypes have their own characteristics, which I think is fascinating.
Now, is this just something that we need to worry about in some research laboratory, or is it important for clinicians to actually consider each patient's specific asthma phenotype? And if so, does that change management in any way?
Absolutely. I think the more we learn about asthma, the more it becomes important for clinicians to understand this, because by understanding the characteristics and biomarkers, it gives us the opportunity to personalize the management for each patient. So, we are moving to precision-based care, and I think these are the tools that we need to really make a big impact in patients' lives.
Oh, I love that. Personalized, and the term you used, precision-based care, is that what you said?
That's exactly right, yeah.
Yeah, I like that. I may steal that from you if that's okay.
Absolutely.
So speaking of tools, what are some of the tools that clinicians can utilize? What tests do we have to identify these different phenotypes?
I think one important tool that we tend to forget, and I think it's one of the most important tools, is actually just taking a very detailed history. It's very important to really understand what the patient's symptoms are, what the triggers, their environment, social circumstances. I think that really can help. But when it comes to objective tools, we definitely have blood testing. We have skin testing at our disposal, breathing tests. So some of the important tools would be checking IgE levels or eosinophil counts. Spirometry and exhaled nitric oxide tests have also been very helpful at helping assess asthma.
And before we get into some specifics about biologics and how we really use our understanding of the immune system to truly personalize care, can you just touch base with the different types of asthma medications available? And I know that always causes a lot of confusion for patients.
Yeah, no, I think that's very true. So, I think the way I think of asthma is you definitely have that inflammatory component, which what we discussed, but also we have that bronchoconstriction component. So for this reason, therapies like inhaled steroids, anti-leukotrienes, anticholinergics, bronchodilators have been used as first line of therapy of asthma for many years. Now there are new and updated guidelines that help address the proper use of these medications. But most recently, we're entering, biologic therapy, which has been very important in the management of particularly of moderate to severe asthma. And biologic therapy can help target at the root level or the mediator level. So it's really focusing on those inflammatory, proteins and mediators that are at the root of inflammation in asthma.
Can you tell us just in generic terms, what is a biologic? What do you mean by that?
Sure. So biologics are a variety of products that are either derived from human or animals, and they're created using biotechnology. So some of these biologic agents contain proteins or antibodies that suppress or activate components of the immune system or the inflammatory response.
And you mentioned that these are a little different than some of the classes of medications. There are broad classes that sort of treat various, types of inflammation and things like that, whereas biologics target specific parts of the immune system. So what types of biologics or what targets have been employed for the last decade or so in regards to asthma management?
Yeah, so the first biologic that we had that we've been using was omalizumab, and omalizumab targets IgE, and it is a terrific add-on therapy for management of allergic asthma. But over the most recent years, we've seen other biologics that block IL-5 or the eosinophilic pathway. So these include things like mepolizumab, rituximab, and benralizumab. And then as time went by, we also found other biologics that target, the IL-4, IL-13 pathway. For example, Tezepelumab is one that targets the alpha subunit of the IL-4 receptor, so it blocks the effects of IL-4 and IL-13. And what's exciting is that just recently there is Tezepelumab, which is the first of its kind, and that one targets the thymic stromal lymphopoietin, which is short for TSLP is short for thymic stromal lymphopoietin, and this is produced by the endothelial layer in the airway.
Okay, so sounds like there have been three specific sort of targets up until now with the new introduction of Tezepelumab, which focuses on this TSLP. And before we get into specifics of that, can you just speak to, in general terms, you mentioned add-on therapy for Xolair and omalizumab. When should biologics be considered in general for treatment of asthma? Is this something that people should be started on, the first day they're diagnosed, or when should we think about this in the algorithm?
Yeah, so as I mentioned earlier, we do have great guidelines that help us manage asthma, but biologic therapy should be considered as add-on for treatment of moderate to severe asthma that's not controlled despite appropriate therapy. And this is a form of therapy that we should consider in patients who have recurrent exacerbations, asthma-related emergency room visits or hospital stays, or frequent need for oral steroids. We also have to consider those who have persistent symptoms despite having max therapy. And we use, asthma control questionnaires to assess control for that. But yeah, the goal here is to really do a step up fashion approach in the management of asthma and really try to get control with other forms of therapy before we think about biologics.
Okay. Well, all right, let's go back to the new biologic that's the focus of today's conversation, the Tezepelumab, and you mentioned TSLP.
Yes.
Before that, you talked about eosinophils and interleukin-5 and interleukin-4 and things like that. So tell us more about this TSLP and how that contributes to asthma.
So TSLP is at the top of inflammatory cascade, and what it does, it is triggered by viruses, pollutants, allergens, bacteria, and other stimuli, and this leads to allergic inflammation, eosinophilic inflammation, and it stimulates both. It stimulates Th2-driven mechanisms, but also Th2 independent mechanisms. So I think it's a key player in asthma.
And when they conducted the clinical trials to investigate Tezepelumab, did they select specific types of patients, or did they really focus on those who only had eosinophilic asthma or Th2 inflammation or anything like that? And what outcomes did they look at in these studies as well?
Yeah, so there were two key studies that looked at the role of Tezepelumab for treatment of severe asthma. One of the studies is called the FAAAAI study, and what that was a phase 2 randomized double-blind placebo-controlled trial using Tezepelumab at 3 different doses versus placebo, and they enrolled, they had 550 patients in the study, and they monitor them for 52 weeks. And what they found in that study is that at the current FDA-approved dose, which is 210 milligrams every 4 weeks, Tezepelumab decreased exacerbation rates by 71% compared to placebo. And what was nice to see is that it didn't matter whether they had high eosinophil counts or low eosinophil counts. It showed benefit. The second study that's key was the Navigator study, and that was a phase 3 multi-center randomized double-blind placebo-controlled trial of over 1,000 patients, and these were aged 12 to 80 with severe uncontrolled asthma, and they were randomized to receive Tezepelumab 210 milligrams every 4 weeks versus placebo for 52 weeks. The endpoint of the study also assessed patients with eosinophil counts less than 300 cells per microliter. And the treatment group showed fewer exacerbations, improved lung function, improved asthma control and quality of life. And this was also found to be true irrespective of eosinophil levels. And the Navigator study showed 56% decrease in asthma exacerbations. So very exciting to see that.
And I like seeing the clinical outcomes of asthma exacerbations as opposed to just looking at markers of lung function or things like that. So it sounds like these were pivotal trials, as you mentioned. Did they find any significant adverse reactions through the clinical trials or anything we need to inform patients about?
Yeah, so, with any injection type of medications, we always worry about injection site reactions. But, the adverse events were really minimal. There were reports of nasopharyngitis, arthralgias, and back pain, but that was seen in 4% of patients compared to 3% of patients in the placebo arm. So very, very safe.
Okay. What are the details regarding administration and prescribing Tezepelumab? How is it dosed? How is it administered? Are there age restrictions? Tell us a little bit more.
Yeah. So what is nice is that this product is approved for ages 12 and up. So adolescents and adults, and the dose is the same. There's no need to adjust based on weight or age. It is a standard dose of 210 milligrams every 4 weeks. It is administered subcutaneously. It comes with a prefilled syringe. So it's a, pretty easy standard dosing, which makes it nice. There's no risk of anaphylaxis that was noted in the studies, which is very nice.
Okay. Help us understand how to find the best patient, the proper patient selection for Tezepelumab, and how that differs from the other biologics currently available. You spent a lot of time talking about phenotypes and biomarkers and things like that. How can we add this to the milieu, and how do we decide when to use Tezepelumab?
Yes, so what makes Tezepelumab unique is that it fills a special need, which is the ability to treat patients who did not qualify for other biologics in the past, based on their biochemical profile. So particularly for those who had low eosinophils or had low IgE levels. So again, this definitely is a good opportunity to use a new form of therapy in this group of patients. But yeah, it is not uncommon to see patients who qualify for more than one biologic, and this could be based on their biochemical or phenotype, if you will. So some of the factors we always have to consider when starting a biologic includes, any age restrictions, the form of administration, whether it's in the office or at home, and frequency, and of course, if there are any other comorbid conditions. So shared decision making definitely plays a key role when considering biologic agents.
What about head-to-head studies with these different biologic treatment options in asthma? Do we have any of those studies to look at as well?
So unfortunately, to my knowledge, I don't believe there's any clinical studies that compare one biologic from another at this time.
Okay. Well, help us think through patients who are already receiving one type of biologic, and maybe there are clinical indications to transition to another one, particularly if they're not responding well and they continue to have exacerbations or symptoms. Is this something that should be stopped all at once? Should sort of one be tapered as the other one is started? Do you have any thoughts on this clinical conundrum?
Yeah, so that question comes up quite frequently in our clinic. But there are no set guidelines regarding discontinuation or switching between biologics. There's limited data regarding whether we should overlap or have a washout period between biologics. So, obviously we need to consider potential adverse effects or, the cost of doing this. Now, I do understand that there are some case reports that show clinical improvement and an improved control when switching, say, from omalizumab to mepolizumab or benralizumab or dupilumab. There's also some data to suggest that, that looked at switching without any washout period. And what we found is that there is improvement of asthma control, lung function, and reduction of asthma exacerbations, and it did not result in adverse effects. So therefore, it's potentially feasible to just stop without a washout period, but clearly there is, opportunity for more research in this area.
Mm-hmm. Well, I think your perspective is very helpful for our listeners, and we'll certainly direct everybody to just continue to follow the Academy website and any communications regarding updates or new tools that can help clinicians best utilize biologics for their patients. Well, you've really discussed some exciting, times in regards to just options that we have available to help all of our patients with asthma succeed and gain control. Do we still have knowledge gaps regarding biologics or other ways to treat asthma?
Yeah, I think this is a growing field for sure, but some of the questions we have, like long-term effects of biologic therapy, or the use of biologics in certain populations, such as the very young or the very old or in pregnancy, those are areas that we still need to gain a better understanding. But I'm confident that research is definitely on its way.
Sure. Well, let's talk about your interest in healthcare disparities. Can you help us understand why it's important to make sure that we have underrepresented minorities included in clinical trials in the first place?
Sure. So, I think it's not only ethnic or racial groups that are underrepresented in research, but like as I mentioned before, elderly oftentimes is not included as much in research. And the other thing that's important to highlight is that asthma is a heterogeneous disease, and genetics, the environment, social determinants of health all can affect asthma care. So I think it's very important to focus on different groups of patients to get a better understanding. Now, one thing I didn't mention is I'm originally from Bolivia, so perhaps you heard some of my accent along the way. So I'm I'm Spanish speaking, and what got me interested in health disparities is when I learned that asthma disproportionately affects certain groups. So for example, asthma mortality rates among African Americans and Puerto Ricans are 3 times higher than those among Caucasians. And same goes for their emergency room visits and hospital rates. So again, a lot of opportunity to do more.
Well, along those lines, if we know that asthma does disproportionately affect certain groups, do we know if these same groups, especially those from underserved areas, have access to these biologic treatments that you've discussed? And if not, how can we make a difference in that realm?
Yeah, so access to overall healthcare is definitely a big hurdle for certain patient populations. Missing work to go to a doctor's office, that alone, and of course the cost of medications can also be prohibitive and contribute to poor asthma control. The good news is that there are some patient assistance programs that can help fill the gap and make these type of medications more accessible, but there's always room to do more and help those patients in need.
Sure. Well, as we sort of wrap up here, I do like to ask our guests to make predictions, knowing that, well, of course, we'll never hold you to anything that you say here, but I think it helps offer some insight into how experts such as yourself, think about progress in different areas. So, if you're up for it, and if you had to predict, do you think that we'll ever find a cure for asthma, and why or why not?
Great question. So I don't believe we'll find a cure. And I think the reason for that is because it is such a heterogeneous condition. So again, no two people are the same. However, I do believe we've come a very long way, particularly in the last few years, and we have better ways to understand asthma and treat this condition. So I think research is going to continue to get better and better, and we can definitely make a huge impact in the lives of our patients in years to come.
Dr. Siles, you've been more than generous with your time today. I think this was an extremely helpful conversation regarding this exciting new treatment option for all of our patients with asthma. And before we depart, are there any other final thoughts you'd like to share with our listeners?
No, I just want to take this opportunity to thank you, Dave, for what you're doing for our listeners. And also I want to thank the FAAAAI for allowing me to participate in this podcast.
Oh, it's our pleasure. Thank you again.
Thank you.
We hope you enjoyed listening to today's episode. Please visit www.AAAAI.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Google Podcasts, or Spotify so you can receive new episodes in the future. Thank you again for listening.